Welcome. I'm Dr. Vinay Prasad. I'm a hematologist-oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode. This week on Plenary Session, we have the modeler's modeler, the modeler who got things more accurate than most, Youyang Gu. Youyang Gu has an undergraduate degree from MIT, and he was not in epidemiology prior to this pandemic, but he is now, and he's got a lot to say on this pandemic. You won't want to miss this discussion. You know, normally every week you hear me say, if you're a fan of this show, go support us on Patreon. You'll get access to the slides. I got something new to say this time. I think the good old days are over. We're living in a unique time where people are very happy to extinguish voices and ideas that they deem unfit for consumption. And so I personally have gone on Patreon. I've supported a number of people who I listen to, the podcasts that I love, and I'm encouraging you to do the same. The only way we can combat this growing force of illiberalism is to support with our dollar bills podcasts we enjoy. So that's my plug. I'm back in Plenary Session. I'm joined via Zoom by Youyang Gu. Mr. Gu is the modeler. He is the modeler, and you may know him from Twitter and other places. I mean, he is the person who's modeled COVID-19 projections.com. He's the person who, you know, I think by many accounts is the most accurate COVID projector, COVID forecaster, COVID modeler. We can see what those words actually mean. And it's a pleasure to talk to you. Thanks so much for doing this.
No, it's great to be here, Vinay. I'm really looking forward to chatting with you. I've seen a lot of your posts on Twitter, and definitely a lot of it resonates with me. So I'm excited to have a discussion here today.
I look forward to it. And you've listened to some episodes. You've listened to Francois or people like him.
Maybe just like a snippet or something.
Okay.
I think I didn't get the chance to
fully delve
go
in.
through the whole thing, but
So I wonder if we might start in the beginning. I guess, I read this recent profile about you. It turns out you're 27 years old. You're a young man. You've got your whole life ahead of you. Trust me, it's all downhill from there. But you're somebody who has basically taken advantage of these publicly available data sets and applied a different algorithm, machine learning algorithm. Maybe you can talk about what your algorithm is, but you've made a number of models make predictions throughout the course of COVID-19. One of the differences between your models and other models is your models are much closer to what actually happens than other models. So I wonder if we might go back to the beginning. It's March, it's early March. People don't know what to make of COVID-19, and Imperial College London drops the bomb of, potentially 1 to 2 million deaths. And I think it was something like 1 million deaths if you did everything humanly possible and 2 million deaths if you didn't do anything at all. You came in then and you started doing your modeling. I wonder if you might tell us a little bit about what were you doing in March and what did you think about in those moments?
Yeah, so I think March last year, it seemed like such a long time ago now, but back in March, I think it was an unfortunate time, and we basically had a nationwide lockdown. And I, along with, I'm sure many other people, were just anxious about what's going to happen in the future. Right. So I wanted to know,
right.
And many others wanted to know, right, when would this be over?
Yes.
So I think, I was just Googling kind of existing models at the time, and it was just a huge range, right? It can be anywhere from, I don't know, like people were saying like 60,000 deaths, by end of summer to, right, the Imperial model said, 2 million deaths if we do nothing.
Yeah.
And so that to me doesn't seem right. So I just, I have a background in statistical modeling. So I just had some free time at the time. And so I just said, why not? Let me just code up this model really quickly and see what that gives me. And so I just took a couple of days to put it together, and then why not just put it on a website and let people see it? So that's kind of how I got started. I didn't expect it to, be where I am now, but, I'm thankful for that.
You make a lot of models. Okay, so let me so tell us a little bit how what's going on under the hood. So your model is basically predicting the number of people infected, and I believe you also have had predictions of the number of people who will die. I mean, you've predicted these different things. What are the inputs that go into your model? I mean, I guess what are those inputs you're putting in? And my understanding is you're using AI or machine learning to actually project into the future. And so it might be a little bit of a black box exactly how they're weighing the different coefficients. But you're not making sort of, unlike these other models that make sort of a simplistic world assumption that there's susceptible people and infected people, and there's a certain rate with which they come into contact with each other. You're not doing that kind of modeling. You're basically putting in all these variables that you've ascertained, like I guess the number of people who live in a county, or you can tell me what the variables you're putting in, and AI is predicting what it will be at X point of time in the future. Is that right?
Yeah, no, more or less. This is a good high level overview.
Okay.
So what I do is, so I had a model that forecasted deaths. That was the main goal, from April to November.
And you pick deaths because it's more stable than cases when you have a changing, testing strategy.
Yeah, so the output, I chose deaths because that's what people most cared about at the time, is how many people would die.
Okay.
And then, of course, when looking to kind of what type of data, what sources should I use to feed into the model to be able to predict that, I looked at a lot of different sources. So like cases, testing, right, hospitalizations, of course, deaths, mobility also. So, and what I found is that all the data is noisy. They're all extremely noisy, but deaths is the least noisy. And so I ended up choosing only to use deaths to forecast future deaths, because I think there's just too many degrees of freedom that you have to basically take additional time to account for if you start adding like cases or testing and things like that. It's just not a consistent, reliable metric, especially because all the different states have different reporting standards. But at least for deaths, it's more consistent.
Yes.
And then what I do is I kind of build this what we call an SCIR model, but it's kind of rather than kind of
you did build such a model,
continuous like differential equation based model that you see in epidemiology. I use kind of a more state machine discrete model, so that's kind of more common in computer science. But that's what I'm familiar with, so that's what I built. And then I just had kind of a machine learning layer on top to learn the parameters into this SCIR model.
I see. So you did use
so rather than kind of using, like solving for differential equations, I just let this machine learning tool. I mean, it's just basic grid search. So it's nothing super complicated. I know like people make it sound like it's this super complex algorithm, but really it's just, I try all the different parameters and see which one fits the data the best. And I use those parameters to forecast the future.
I see.
And of course, right, it ended up working pretty well.
But tell me, in the original data set, like how many variables are in there? 6, 7, or 100 or 200? Probably 100, something like that. 50, 100?
What do you mean by variables?
I guess in the original data set that you're making the forecast from, you were including in there, are you using any population parameters, the number of people in the county, or you're using any data?
Oh, yeah, no.
It's strictly just the number of deaths? Yeah?
Yeah, and I guess so I was doing forecasts for kind of each state in over 70 countries. So I just use population.
Population, okay.
That's it, yeah.
So population, and then the number of dates to date. The number of deaths to date.
Number of deaths.
Deaths to date.
Number of daily deaths.
And then what else?
And that's it.
That's it?
Yeah. That's
okay. I see.
I mean, if you think about it, right? Like
yes.
if I'm doing forecasting for 50 states and also 70 countries, each country is going to have different sets of data and so it's really difficult to kind of having to
yes,
kind of
I see.
build all of that information.
okay.
So, deaths is kind of the only reliable.
Okay, wait. So population is one column. The next column is the deaths by every single day, though. You're putting in the day every single day as a column. Okay, right. Okay. So I'm seeing it. So I guess it's based on how much follow up there is, maybe. But surely, the number of deaths that happened 45 days ago is not weighted as heavily as the number of deaths that happened 2 days ago. Where does that come into the model?
Yeah, that part is the kind of the tuning. So you could pick the weights for the different days. I spent a lot of time figuring out the right combination of weight. You could do like an exponential moving average, right? Where you weigh the past days less than the future days. But it turned out that what I found works the best is you weighing each day equally.
Really? Oh, okay. Yeah, interesting.
And because it turns out that, right, like when you have exponential curves, then when you weigh the tail heavily,
it's all going to explode.
Then it just ends up fitting to the last week.
And
it doesn't take into account, right, all the previous days.
Yeah, I can see that. Okay.
And so, so I mean, it's it was a lot of tuning, but there was a lot of concern about kind of overfitting, because if you just care about, right, like maximizing kind of this in sample error, then you'd want to just weigh the end days more, because you can basically fit the curve.
Yes.
But that doesn't work out of sample.
Yes.
So I think that's a problem probably a lot of other models face, and maybe they didn't really quite get the kind of validation correct. But for me, it took me spent kind of a couple of weeks trying to tune these weights, and it turned out that at the end I was like, well, just weigh everything equally. And,
I see. When you use the word tuning, somebody listening might wonder, like, are you trying to optimize a parameter like R squared? You're not trying to optimize a parameter, because if you were trying to optimize R squared, you might weigh more heavily the more recent days. When you take tuning, what are you tuning it to? You're tuning it to the past, or you're tuning it to what future days come?
It's a good question. So, I basically have kind of this set aside this validation period.
Okay, I see.
So
yes,
I have,
you have a derivation validation.
Okay,
yes.
Yeah.
Okay.
So I tune the parameters and then check the results, which is I think I use mean absolute error or mean squared error for the validation test set on the deaths.
Right.
And then, of course, but then if you keep tuning, you're going to overfit.
Yeah, exactly. Correct.
Set.
Yes.
So I basically, pick the country, say Italy, and I tune around that. And then I basically have a validation set for the validation. Uh-huh. So I then let's look at, after I tuned it, I look at Spain.
Yes, gotcha, right.
Did it do better in Spain? If not, then I probably overfit.
Yes.
And then if it did well in Spain, let's check France.
Yes. Yes.
Or New York.
Yes.
Or Jersey. So doing it that way, I think, what ended up kind of working out.
Maybe I'm going to try to explain this to the listener who may not be familiar with this, but I guess, what Youyang is doing, and tell me if you agree with my characterization of what you're doing, is one of the classic problems in data analysis is if you take a collection of data and you try to explain why do these variables fall the way they fell in this collection of data, you can, with enough if your model is allowed to explore enough factors, you can almost always fit some line that explains all the data perfectly. But the reason it's overfit is it's using arbitrary and idiosyncratic differences in the data to explain this line, and it's not actually telling you something true about biology, about the real world. And the first proof of that is if you go to a different data set, like the same country 2 weeks later, or a different country a week later, or a different country a week earlier, and you applied that equation that you think will explain where deaths will fall in that new data set, it will be wildly in error. And so the classic way to overcome this from sort of a methods point of view is you break up your data set into smaller pieces. So if you have one country, you break it into 2 pieces, you derive your equation, you derive your model in one set, and you test to see how well it fits the separate set of data you've kept aside. Overfitting means, I guess, idiosyncratic differences in data are used to create a really nice model that applies very poorly in the next data set. And I guess what you're doing is you're saying you're actually testing this classically we call this a derivation cohort where you build your model, and you have several validation cohorts. That same country in the future, a different country in the past, a different country in the future. And the more different validation cohorts you're applying it in, you're really trying to get at what are the true relationships in the data versus what's the noise that the equation might be fitting, and give you the false sense that you're predicting what's happening, even though you're just sort of taking advantage of idiosyncrasies in the data set. Okay, is that a fair characterization of this process, or how would you put it?
Yeah, no, you explained it better than I could myself. But yeah, I mean, I think, right, that the issue with, I think, what a lot of papers you see in academia is that, right, like that doesn't
happen.
Right, you don't need to validate because you can just publish what you see, right? Like you tune it so that it maximizes the error in your data set, and then you say, "I'm done." Right? You
That's exactly right. That's exactly right. I always tell people, so many projects that I've been asked for my opinion on, and I'm like, if you really want to prove this, and they've played, and so the other thing I want to say is just a side point, is sometimes you have a small data set and you play around in your own data set so much, there's no more validation part left in your data set. You've looked at this data set every which way. You need a totally different data set to try to validate some of these things. You're lucky, I guess, with COVID-19, you have so many countries that you can always find a data set you've never played with before to test it in there. But I think this is a problem. I mean, I think you're getting at something. Okay, so all right, I want to ask you some questions now. Okay, so you do all this. Your predictions are very good compared to other people. Compared to, I mean, we should put in context. Like one of the people you're competing against is University of Washington. They have $500 million from the Gates Foundation for IHME to do this kind of modeling. You probably don't have $500 million. Fair to say?
Yeah, that's fair.
That's fair. Yeah, but your model is better than IHME. Okay, one question. I've heard you say this kind of in passing, and I want to pick your brain on this. When we initially went into lockdown, I was under the impression, it seems like you were under the impression, that the rationale for that was, quote, flatten the curve. The idea that we are going to try to minimize the single day influx of patients into the hospital system so that at no one point in time we overwhelm the hospital system. My understanding of that wasn't that we were going to stay in sort of a perpetual lockdown situation until we were able to eliminate the virus altogether. But somewhere along the way, that did change. Do you feel as if that changed as well? How do you think about this?
Yeah, no, I mean, right in the very beginning, I knew nothing about infectious diseases and knew nothing about the virus. And so, I just, listened to what kind of the public health experts and the scientists were saying, which was, we're locking down in order to flatten the curve. And I think at the time, people were very explicit in pointing out that we're not trying to eliminate the disease, but we're simply trying to, make sure that we don't overwhelm our healthcare systems, which actually, funnily enough, I thought that was odd because I personally at the time wanted to just, why don't we just eliminate the virus, right? Look at China,
right?
Right. Or look at, the kind of, so somehow since in the months since then that seem to have changed. And now there's this idea that we have to seem to completely eliminate the virus for things to kind of go back to normal. And so not really sure where or how that changed, but I guess it did. And, that's just something that is interesting.
Yeah, I think it's quite interesting. I mean, I feel like it happened right around that time. That guy wrote that Medium article, The Hammer and the Dance, or whatever, The Sickle and the Sword, or whatever the hell it was. And that's where I felt like people who've been in this business for many years changed their tune, which I thought was quite crazy. Okay, I want to ask you about two things you recently posted on. The CDC mask mandate and then the school closure data. I wonder, maybe we'll do, which one do you want to do first? I wonder if you might explain like what's going on here. The CDCs are doing
do the mask.
Let's do the mask. Okay. Yeah. Okay. Take us through this. Or maybe I'll just frame it by saying, the CDC did some study, which this type of study, by the way, for the record, I want the record to state this is considered one of the lowest forms of evidence in medicine. But basically, they looked at counties in Kansas with the mask mandate and counties in Kansas without a mask mandate, and they argued what exactly, and then you did some secondary analysis and you found something different. So take us through this.
I think like the CDC in November or December released a study that looked at Kansas counties and the mask mandates back in, I think, July. And they just basically looked at only like a 1 month period, after the mask mandate or 6-week period, and said, hey, look, like, masks, counties in, with the mask mandate had a lower, kind of infection rate than, counties without a mask mandate. And so therefore it seems like mask mandates work. And I think that was their conclusion. And what I did was like, okay, well, let's see what happened in the weeks and months after the mask mandate. And it didn't matter whether counties had a mask mandate or not. The infection rate spiked in September and October, kind of pretty much arm in arm. And so, this conclusion that somehow mask mandates is effective at reducing spread. I'm not saying that they're not effective.
Right. No, right.
I'm just saying that the data doesn't support that.
Yeah.
It's incredibly effective.
I mean, I guess when I saw your figure, it was like, I don't know. It's like a single figure when the moment somebody looks at this figure, and I'm going to tell people it's on December 16th on Youyang Gu at Youyang Gu on Twitter. The moment you see the figure, you're like, oh my gosh. Because, I mean, not only is the time period they report, there's a difference, but the future time period, there's no difference, as you note, and the actual rates at which the infection's occurring is like way, way higher. It just explodes in every place. Fair to say?
Yeah. And I guess it is a little bit odd because at the time that the paper was published, I think it was like November or December, this was already, like we already know
they already knew it.
They exploded. Right. But they still chose to publish it. And then of course we had people, right, citing that paper as, to say that, hey, like mask mandates work. We should implement mask mandates. So that was just, I think, unfortunate. I mean,
I just make one point here before we talk about the other example. I actually believe, and this may sound kind of surprising, but I believe, you're never going to find truth on some issues from these types of studies. So for instance, in this case, people have a strong belief, both sides. I mean, there's some people there's a faction of people who don't believe they work, and there's a lot of people who believe, I think there are a lot of people in the middle who believe it might work but have a modest effect size, and there are a lot of people who believe it's an art, they ardently believe in this. And when you have such an environment and you have basically near infinity data sets. I mean, the number of data sets here are how many states, how many counties, how many different mask mandates they had it or didn't have it. I mean, maybe not infinity, but we're talking about maybe 10,000 data sets globally. I mean, you can pick the data set you look at, and you can pick the time period. I mean, you have total flexibility on the time period you look at, the data set you look at, how you define quote mask mandate. Like if there's a county where they kind of recommended it, but they didn't always enforce it, which bucket you put it in. You give them there's researchers all this analytical flexibility. You're going to find whatever you want to find. I mean, you can go in some of these data sets, you'll find it works. You go to other data sets, you find it doesn't work. I mean, I think the only ways around that are like total pre-registration of the analytical plan, where you're going and where you're looking and why you chose that to look at. Even then, I have my doubts. And that is actually why, there are a few of us who thought you could actually do some cluster randomized trials and you'd answer that question.
Yeah, and you brought it up as well, right? There's this heavily selection bias in all this, right? None of this is random. the selection of counties that received a mask mandate, not mask mandate, completely not random, right? The places that got a mask mandate
They take it
tend to be
seriously.
cities, and they tend to be more left leaning.
Yeah.
Who there will be higher compliance with the mask mandate anyways.
Yes.
And also places that implement mask mandates probably do so because there's already have been a large surge in cases.
Yes.
And so when there's already a large surge in cases, then if you look at what happened 6 weeks later, of course, there's a high probability that cases would go down versus places without a mask mandate. Well, they didn't implement a mask mandate because there's no high prevalence in those counties. So in 6 weeks, of course, it's much likely that prevalence will go up. So there's just really no way whatsoever to really kind of deduce anything from just kind of these few data points. But of course, because it is a CDC, I think a lot of people paid a lot of attention to it.
Yeah, it took me 10 years in medicine to learn what you just said. So thanks for for coming to the conclusion years before I did. Okay, now I wonder if you might talk about what was the new one that was really
university.
Yes.
Counties.
Yes, university counties.
Yeah.
Yeah, talk us through university counties. I'm trying to find it.
Yeah, so I mean, the
CDC report from January. Okay, here's what you're saying.
Yeah, so 2 months later, they released a report saying that they looked at kind of school reopenings, or more specifically kind of college and university reopenings from kind of July through August. And they compared counties, university counties with in-person instruction versus remote instruction. And so they only look at the 3 weeks before and after. And so they concluded, colleges, university counties with in-person instruction saw a rise in cases in the 3 weeks after the reopening versus university counties with remote instruction. And so therefore they conclude that we have to be careful about reopening schools for in-person. So that was their conclusion. And so, of course, I thought, why not? Let's look at what happened in the 6 months after the reopening rather than just the 3 weeks after. Yeah. And it turned out that the counties with in-person instruction actually ended up with a much lower peak in the fall than counties with remote instruction. So basically, the idea that that in-person instruction somehow leads to higher prevalence in the community is not supported by the data, at least kind of over the long run. So that's kind of the high level conclusion there. So basically pretty much the same thing as the mass study, right? You find some correlation in like the near term, right? What happens right after. And then, but if you actually look at the long term, that correlation basically goes away.
That's fascinating. Boy, that's like, I mean, the policy implications of this are tremendous. I mean, this is literally used to make these decisions, these kinds of things. And the other challenge is like your point about it. Which is incredible, I mean, just overwhelmingly persuasive and right. It's just not going to be known by as many people as the original study, because that study got the school reopening counties. I mean, that got so much media coverage. It's not even close. Yeah.
And then people were because it's the CDC, they pointed out at the article and said, hey, look, like the CDC concluded that, reopening schools leads to a spike in cases, so therefore we should not reopen schools.
Yeah.
And that's just, again, very unfortunate because they also chose not to look at deaths. And I don't know if that's because they didn't have time or they just intentionally did not include it. But if you actually look at deaths, there is no difference. There's no kind of increase in deaths for university counties with in-person instruction.
So
So if in the places that
so I mean one of the thoughts there is that it could be an artifact of like when they're running the schools, they test like crazy. I mean, the testing goes through the right.
Exactly. That's what I was about to say. When you open schools, a lot of these schools probably have a very strict set of guidelines that you need to in order to reopen, and they do a massive amount of testing. So for example, I think like University of Illinois, right, we've heard at one point they were doing like 5 or 10% of the national tests.
Yeah.
Right. And so of course when you test the entire campus, right, a couple times a week, you're going to find a lot of cases than, counties that don't do these types of testing. And so just because there's more cases, right, doesn't mean that it doesn't automatically mean that, this is something a problem that we need to be concerned about. Right. And it seemed like in a lot of these cases, the incidents and the outbreaks are contained in the school itself rather than kind of spreading outwards to the rest of the community.
Yeah.
Right. So, I mean, just like we definitely need a lot more data and evidence before we can kind of make these types of conclusions that all school reopenings, or college reopenings kind of, lead to higher incidents in the community or higher deaths or anything like that. I just think just kind of taking a few, data points and looking at the 3 weeks after doesn't do it justice.
Doesn't cut it. Related to what you're saying, I always tell people that for some of these municipalities where they say schools will close when some percentage of testing is positive, we're going to close it. And if it's some percentage is below that, we're going to keep it open. And it's always on the cusp, and the parents aren't getting angry. I tell them that all you do is you say we're 100 parents who feel well, you go get tested. Boom, you're bringing that percentage down. You get all the well people and you go get tested, and you can drop that. So if they want to use a metric that, I still will debate it, whether or not it's reasonable, but at least cases per 100,000 is more objective than the percent of tests that come back positive. It's very contingent on whom you're testing. But I also think that with the schools question, we do have regression analysis that shows there's no link between cases per 100,000. Anyway, that's another story. Okay, here's my question for you. On January 24th, the New York Times ran this model, and I think you know what I'm talking about because I've been complaining about it a great deal online. This is a model that said, now that vaccinations are started, it said, don't let up your guard. Like, even though you're right, don't let up your guard, because even if you vaccinate at this pace we're vaccinating, we're going to get so many more cases that go into, all through February and into March. There'll be rising cases and they'll plummet in April. And if you do let down your guard, well, then it's just going to be rising cases, even in April, and then it's going to plummet. And then, of course, what actually happened is the cases just plummeted. I wonder if you, one, did you see it coming? Did you think the models were wrong? Two, what are your, I guess, any thoughts you have on this recent question of the plummeting cases?
I took a step back from kind of like doing heavy forecasting of the future back in November. So now I've been just focusing on kind of estimating true infections in every county and every state, and also kind of forecasting kind of vaccinations and things like that. But I did have kind of since December and a kind of crude projection about kind of infections in the U.S. And I've had infections kind of going down from December onwards all the way till March. And that hasn't really changed in the past few weeks. Mm-hmm. And I mean, of course, I think real cases and infections have fallen a little bit steeper than what I was projecting. But I mean, overall, I mean, if you just look at the data, I mean, there's just no reason to think that we will have another spike kind of in February or January or anything like that. I mean, all the data points to these are just there are going to be waves of these infections, and it doesn't really seem to matter what you do. I mean, of course, there is of course restrictions and interventions can kind of play a minor role, but overall, kind of in terms of like the shape of the pandemic, it's seems to be more or less kind of are baked in rather than kind of able to be controlled. So,
what makes you say, I mean, I guess, what you're saying speaks to my intuition, which is that if one, I mean, I've written an article where I go through all the different factors that can explain the spread, but one is, there's sort of a natural tempo to these things. They have a natural periodicity. And the other thing is there's some things that are outside of control and they're stochastic and chaotic and random. But what makes you say that you think that, and of course, the narrative on Twitter is, of course, that everything we're doing is the thing that's responsible for it going up. We're bad people, and if it goes down, we're good people. They put it all. They almost anthropomorphize everything in terms of that. There's always, the action of some agent. What makes you say that you think some of this is outside our control?
Yeah, I mean, the easiest is just right, like if right, we take this hypothesis that there's actions and interventions that you can take to right control the virus and its spread, then you would be able to create a model, right, that would be able to accurately predict the spread given the actions that you take.
Yeah,
and I don't see a model that did that. I still haven't seen it.
Yeah.
Right. The easiest example is you look at Florida and California, right? Back in September, Governor DeSantis was like, we're going to drop all restrictions.
Yeah.
And, of course, that was a little bold, right? Even,
yeah, it was. Yeah.
But the narrative at the time was, oh, okay, so now Florida is going to have a dramatic wave, a tremendous surge because they did that. But of course, California kept everything, right, kind of very restrictive. I remember,
yes. Very,
very difficult even for outdoor dining. They closed that down, and we saw a huge surge in California. Right, it was one of the worst outbreaks in the country. Did anyone predict that? No, right? So the easiest way to kind of reach the conclusion, right, is if this was possible, then you would see, some kind of model or prediction that would be able to deduce this behavior, right, this pattern.
Right.
But we didn't see
exactly.
That. So, there has to be something else at play, not just interventions or restrictions. So that's kind of how I came to that conclusion.
That's a very good point. So my question for you is, I guess I have two last questions before we go. The last one's going to be on herd immunity, but the penultimate question is, why did all the other modelers get it so wrong? Like, why do you think, I mean, I also want to say just a caveat to the listeners. Like, I believe that if you underestimate, you are penalized more socially than if you overestimate. And if you overestimate 100 times, not 100 times, but 10 times more, there seems to be very little social penalty for that, which there's some research about our moral intuitions there. But whether you underestimate or overestimate, it doesn't matter. A lot of these people are just way off. Way off. Why do you think they're so off? Why are they so off? Why are you so much better than them? What's the difference?
I mean, well, first of all, I've been very off too. Okay. So it wasn't it wasn't that like my model has been perfect throughout this whole time. Right? I've learned a lot from the other modelers as well. So right, kind of we all kind of work together in sort of kind of sharing our ideas and things. But I guess what makes, I think, my approach a little unique is, right, because I don't come from an infectious disease background. So I have kind of zero priors about what a virus can and cannot do. I only focus on my approach is only, right, like look at the data. That's my only focus, was to kind of follow the data as it is. So I didn't have any kind of preconceived notions or biases that can kind of cloud my judgment about what can happen.
They would call that knowledge. They would say that that's knowledge. But yeah, you're saying that that's a hindrance.
Yeah. So I guess, I mean, of course, right, like having background and knowledge is useful. But you have to, right, not be sure to not kind of over rely on your kind of past experience, especially if the data is telling you something different. So I've just kind of throughout this past year, just, relied on the data as much as possible. So if, right, the data tells me that, right, something is not what I expected it to be, then I just change my beliefs and go from there. Right. But I think for people who've been doing this for many years, it may be difficult for a lot of them, right, to kind of see evidence that may go against their beliefs and then change their beliefs because they've, right, been so ingrained with certain kind of ideologies or doctrines. And so that kind of is something that I think could be happening. So I think
I think you're quite right. And actually, I always tell people something very similar happens in clinical medicine, where if you're too in love with a drug or a test or a study or a procedure, you almost will always lose clarity, and you won't reject it even if the data suggests you ought to reject it. Okay, my last question for you. My last question for you is about herd immunity. Which is even provocative to utter those words these days. It used to be, when we started the pandemic, you could say herd immunity. Now you're a bad person. Herd immunity doesn't exist. It's a myth. You've done a lot of work. You're thinking about the rate at which we're vaccinating people, the rate with which people have already had, what you call true infection. I guess I would say, do you think, herd immunity, my understanding of herd immunity is it's not the same everywhere. It depends on the rate with which people mix and the rate with which they do, different activities. I guess, what do you think about herd immunity? Is there a herd immunity threshold? Is there a percentage that you would quote? Anthony Fauci says it's 80%, 85%. He looks at the polls and then tells you what it is, which isn't the way I like to do it. But okay, is there a percentage? Is it the same across areas? Where are we and when might we get there? So everything about herd immunity, what do you think?
Yeah, I think, herd immunity comes up every so often, every few months, it seems like, because, right, I know back in March and April, people talking we should not aim for herd immunity. That's why we should, stay locked down. Mm-hmm. And then kind of in June, July, August, we're saying, are we at herd immunity? Maybe we are, maybe we're not. And then of course now we're coming back to this topic, right, of, now that we have a vaccine, can we get to herd immunity? And my take is, if you've been following, right, some of my posts, it's becoming more and more clear that we are probably not going to reach herd immunity. And the reason I say that is because you look at the polls and, it turns out, right, vaccine acceptance has not been increasing, or vaccine hesitancy has not been decreasing. In fact, it might be even increasing. And, so it turns out that, probably we're going to get about 60, 70%, right, for lucky of the adults who are going to get vaccinated. And then so it looks like children probably won't even get the vaccine this year.
Yeah. No, yeah.
And so you factor that in, right? Even if you vaccinate every single adult, you're not going to get to that 70, 80% level of the population. And then once you factor in vaccine hesitancy, you're probably only going to get about, 60% maybe. And then of course the vaccine's not 100% effective. Right. So you have like the Johnson & Johnson vaccine has 70% efficacy. And then you have kind of the new variants that's coming around that, might drop the, efficacy a little bit. So you put all of that together and, at the end of the day, we probably, won't get to whatever that threshold is, right? 70%, 75, 80, right? It doesn't matter. I don't think that should be our goal. I think the goal should always be, right, the widespread availability of a vaccine that effectively eliminates, severe illnesses and deaths, right? Once we get to the point where anyone who wants a vaccine can get a vaccine, then I don't see a reason why we can't return to normal. And I think, looking at the projections now, we're probably just a few months from reaching that point, probably in December. So, I think, right, what we should focus less on kind of when we get to herd immunity and more on when everyone can get a vaccine, and then we can go about returning to our normal activities.
Yeah, that's, I have another guest coming on the podcast, Monica Gandhi. She says something similar. She says that the moments the hospitals empty out, and that she actually puts it quite differently. I think she just says that you won't be able to contain it. Normalcy will just return. People will just go back to doing what they're doing because you can't even try to enforce the restrictions if people aren't concerned and worried. But I think you're right. So I guess by this model, not by this model, by this way of thinking, you would say that we shouldn't be surprised if in the fall there's an outbreak of COVID-19 in communities that they have chosen not to be vaccinated? Would that be reasonable to say?
Yeah, I think so. I think, right. I think the guest you had last week, right, Professor Francois Ballos, he was like, yeah, like you're going to see another wave, fourth wave, and then a fifth wave and a sixth wave, right? You're going to see those waves, but each one is going to decrease in its intensity, and, they're not going to hopefully kind of, right, like, get as anywhere to what we saw in the fall where we were overwhelming hospitals. So, but, that's fine. Right. People who are vaccinated, they will be very, right, protected from hospitalizations and deaths. And so at that point, right, what's stopping us from going back to normal?
If everyone at risk is protected from the bad outcomes, then SARS-CoV-2 is a cold, I like to tell people. It's really not much.
Yeah, I mean, it's basically becomes a flu, but unfortunately, It seems like we can't really compare COVID to the flu these days. So I guess we have to be careful when we say that.
Yeah, you're right. So I guess maybe I lied. Maybe I have one more question because I guess we still have a few more minutes. I don't know. Have you been surprised a little bit by, I mean, it's just from talking to you, it seems like you're quite an even-keeled person. You're a data person. You're not getting too heated any direction. But you go on Twitter and it's this, one of the things that gets me is, I mean, I feel like there's a group of people and they're like the fearmonger Twitter. And I wouldn't be so annoyed by them, except I think they have the ear of like CNN and the New York Times. And it's just like fear and doom and and just more. And then there's no end to the restrictions that they support. And they are unwilling to consider or do anything about the downsides of restrictions. I see like that's a group. And there's another group on the other end that's not even real. It's not even real. It doesn't exist. I was like, what do you get away. It doesn't exist. You're crazy. So I guess I wonder, I mean, as you put it, you're an outsider, which is good because you don't have any inherent bias, no strong held convictions. And then the last thing I'd say is, and there's a lot of people in the middle who try to, there's a big broad middle of people. A lot of us are silent. I think a lot of people in the middle are silent because they're scared of getting, pushed to one extreme or attacked. And then that's the other thing I'd say is there's a lot of like attacks. I mean, personal attacks and name calling. I feel like you've kind of stayed out of most of it. Maybe just personality wise. I guess I'm curious what your thoughts are on the state of the dialogue.
I mean, this past year on Twitter has definitely been a learning experience for me. I wasn't even on Twitter before the pandemic, and I mean, I noticed that right, like our dialogue is so polarized that right, you have basically very few people kind of in the middle, and you just have groups of people on one side or on the other extreme. And, for me, I guess, I take pride in knowing that I get attacked from, both sides. And also, right, they also use both sides, but I've also used my, analysis and data to support their, ideas. And so I think that kind of is a good, sign for me that I'm kind of doing things right in the sense that, right, like, both sides can find criticism in my work and also find things that they find useful. But yeah, my goal is always kind of like to just be as level-headed, realistic, unbiased, unpolitical, no agenda, kind of doing that analysis. And I'm happy to take as much criticism in the process as possible as what happens. So
yeah, I guess that's well put. I'm close to you. I mean, I have no political agenda, and I'm happy to. I mean, even if I see a politician who I like or dislike, just because I like them, I'm not going to take it easy on them, and just because I dislike them doesn't mean if they say something true, I'm not going to agree with them. I'm going to agree with them if they say true. But my biases are, I do have biases because I've been in medicine for, I guess, 15 years now. My biases are, I think, that people oversell low levels of evidence, people believe that human beings control our destiny in a very strong way that often is not fully true. And I think you should always think about other things that may be leading to outcomes. And randomness. I think people have a very bad job of thinking about randomness. I think one of the other principles I have is emotional availability. Things you see being counted and scored are much more present in your mind than things you don't see, that you don't think about, you have difficulty imagining. That's why I think the schools discussion has been a fiasco, because they see the deaths. They don't see the kids getting somebody putting a cigarette out on their back and, nobody's there to stop that. They don't see that abuse. So I think that's one of the biases I have. And then I think measurement. I think that my big bias is that measurement is really awful, often awful. If you don't do the same measurement in the same way, with the same test, with the same ability to get the test, and, if you're changing that over time, as you point out, you pick deaths because it's much more, that's a wisdom, because it's much more stable. Even deaths, there is some adjudication of death. And excess death is another metric, which I think is reasonable. But the problem with excess death is, it can get at things that are not the downstream sequela of the thing you're worried about, the virus. And I guess, so, a lot of these questions on, I've written about these things. My honest view is I don't know how much lockdowns work, beyond, the intervention. The first intervention is you go on TV and you say, shit, look at the cases going up. Their cases going up. It's really bad. That scares people. They're going to change their behavior. Then on top of that, you lock them down. Well, what's the lockdown effect? I don't know. You have to separate that from scaring me. I mean, when I'm scared, I stay in my house. Of course I am. I don't want to go out there. But I have to go to work. But, those kinds of things. So I guess I don't know what all these things do. And then the last thing I'd say, my bias is that I do think human beings from 100,000 years ago to now, when you're scared and anxious, you slaughter a goat. By that I mean, one of the things you do is like slaughtering a goat. You slaughter the goat because you think that the spirits will give you good omens and the problem will go away. We don't slaughter goats anymore. That's obviously, that's obviously doesn't work, but we do similar things. We take rims off basketball hoops. We rip nets out of tennis courts. We close playgrounds. The closing 1,000 years from now, closing playgrounds for this disease, that's slaughtering a goat. It's just doesn't have anything to do with anything. So I guess I would say those are my biases, if I have biases. And then my last bias is I love debate. I really do like when I see people debate, and I really hate when they make it about personal things and they don't debate the content. And so my bias is always pro-debate. And when I'm uncertain, I want to hear a debate. And then I guess the last thing I'd say, before I give you the final word, the last thing I'd say is the thing that kills me the most about this modern culture is I've had some guests on my podcast with, their huge range of views. A very broad range of views. I've had some guests that people say, you should not have interviewed John Ioannidis. I was like, this dude is the most cited researcher. And maybe he is not 100% right. He's a human being after all. But maybe he has something interesting to say, and he's an interesting person to talk to. I don't know. But this culture that we can't talk to people, I think, you might as well put your head in the sand. Okay, so those are my thoughts. I'll give you the final word. Thank you so much for doing this. I find your threads very insightful. They make me think.
Yeah, that's a very good way to summarize everything. So I don't know if I can necessarily top that. But no, I've learned a lot over the past year, especially on Twitter, and kind of my take is just kind of always just be kind of critical of what's going on. I think it's important that we don't always just kind of look at what the media says and just kind of go along with it, because it's always there's always usually some sort of agenda or bias behind it. And then, of course, that's not a mean to say, go out and deny COVID, right? So it's a very fine balance, right? Between just kind of challenging the status quo versus just outright denial.
Right.
So for me, kind of my goal, at least, right, through this whole time is to just kind of walk that line, as carefully as I can. And, that I'm not always perfect. Right. So I made mistakes too, where I strayed too far on one side or the other. Mm-hmm. But I try to come back whenever I catch myself doing that. And, I hope, more people can kind of, see, right, the work that I do and the work that you do as well. And just say like, maybe like what they're saying disagrees with my beliefs, but maybe they have a point.
Yeah.
Right. Maybe, just maybe, like there is a reason why they're saying that. And to just kind of give them some further consideration and go from there. So, but yeah, no,
yeah.
It was great being on, being here today. And, hopefully this was helpful to the viewers who would be listening, or listeners who would be listening to this.
I think they're going to enjoy it. Youyang Gu, thank you so much for doing this. A pleasure.
Yeah. Glad to be here.
You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.